really high mortality and morbidity rates with breast cancer. We started understanding that cancer spread and it was metastatic. But our mortality rates were pretty terrible, so we still were non-op. Next slide, please. In the early 1900s, Sir William Halsted started giving us some profound research in the Annals of Surgery. He reported on what he dubbed the radical mastectomy for breast cancer. Next slide. He thought that breast cancer was contiguous, so it spread this way. So a more radical operation would yield a higher chance of cure. In his surgery, he included the breast, the skin, both pec muscles, and a complete axillary dissection, so all of the contents under your arm. The wounds healed by secondary intention, meaning that we didn't close them up because they were way too big, or we had to do skin grafts. Complications of lymphedema or arm swelling, chronic pain, and nerve injuries, because there's several nerves that run under your arm that control your back and your shoulder, were fraught with contention. Next slide, please. This is a picture of what his mastectomies looked like. Guys, this is what we did until the 1970s. I mean, how barbaric is that? And as a surgeon that has never seen one of those, I cannot imagine having to do that to a patient. But luckily, we had change on the horizon. This is Dr. Bernie Fisher. He was instrumental in starting the NSABP, which is the National Surgical Adjuvant Breast and Bowel Project. This is the reason we have so much data and money going into breast and colon cancer research. This is when it all started in the early 60s. We also started having chemo. It was terrible. We didn't have ports. Like Coach B said, it was going into your veins, and it was poison, but it was a systemic treatment for a systemic disease because cancer is systemic. It's not just where we find the tumor. Mammogram also came into the forefront. This is also a game changer. Mammogram was developed in 1966. In the 1980s, Europe started with its initial screening recommendations. This is a great tool to detect breast cancer early. The machines were huge, probably the size of half of that room in there where our raffle is, just like the first computers were, but that was what we had. The recommendations have changed, but my society, the American Society of Breast Surgeons, as well as ACR, the Radiology Society, we recommend, starting at age 40, an annual mammogram. Mammogram's the gold standard. It's the only test we have that can detect calcium, which is the early stage of most breast cancers. Okay? It's not perfect, and we have some adjunctive things we can talk about too, but that's what we do. Next slide. So the first trial I want to talk about, and this is going to show that we can go from what Halsted was doing, mutilating women, to saving our breasts. So that's where we're going to be headed. The first trial was in the early 70s, and basically compared Halsted's mastectomy, taking all of your chest wall, to just taking the breast. It also added some adjunctive radiation therapy. And we found in 3, 5, 10, and 25-year follow-up that less radical surgery does not affect our survival. And radiation helps to decrease local recurrence. So a few years later, we then compared mastectomy with breast conservation therapy, or as many of you know it as a lumpectomy. Can we save a woman's breast? Can we not take away what makes her feel like a woman and fight this disease together? So the answer was yes. Radiation, along with lumpectomy, was not inferior in either recurrence in the breast or in overall survival. So we can save the breast. We don't have to mutilate a woman to do this. Next slide. Okay, what about your underarm? Do we have to put these women at risk of lymphedema, chronic pain, and nerve damage? So we had a couple of studies. Then, slide. The first study, now we're getting close to today. This is 15 years ago. Was the Z11 trial. It said if a woman came in with a clinically negative axilla, meaning that she didn't have any lymph nodes under her arm that we could feel, or that on imaging looked positive, can we just do a targeted sampling and not take out all the contents of her axilla? These women were getting radiated anyway, and the axilla was included in their radiation field because they were undergoing breast conservation. And the answer was yes. We don't have to take all that tissue. Again, these were only lumpectomy patients, so at the same time, in this next trial we'll present, Europe was looking at both mastectomy and lumpectomy patients. They radiated the breast and chest wall in both patients, and again, they showed that overall survival, disease-free survival, and recurrence in patients with early-stage breast cancer with a clinically node-negative axilla, or they didn't have anything that we could feel when we examined them or on their pictures when they presented, we don't have to clean out their axillary contents. Okay? We still have ongoing research. Next slide, please. We're looking at women